the first board meeting of 2024. Appreciate the board members coming up and participating this morning in a board development session that was very productive. And hopefully we can get this meeting accomplished with all due speed. The first thing we need to do, Mr. Moody, would you give us an opening prayer? And if everyone would stand for the prayer and also for the Pledge of Allegiance afterwards.
Our kind Heavenly Father, Lord, we thank you for the opportunity that you give us to serve on the board to try to make things better for our Mississippians. Lord, we thank you for each and every one of the members that are here to devote their time to this effort. Lord, we just thank you for your love, your mercy, and your grace that you show to us each and every day that you allow us to live in your world. Lord, we just pray that each and everything that's said and done be in accordance to your will. Lord, we thank you so much for sending your son Jesus into the world, that through our belief in him, we might have life and have it everlasting. These things we ask in your name. Amen.
Amen. And now for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America, and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. You may be seated. First item on the agenda is the approval of two sets of minutes, one from October 11th, 2023, and one from December 12th. There's a motion. Is there a second? Second. There's a second. Any further discussion? All in favor say aye. Any opposed? Now it's time for Dr. Daniel Edney, our esteemed state health officer's report.
Thank you, Dr. Lampton, and thank you, board members. I'm excited to bring some helpful information to you today to guide you in your work as you guide us in ours, and we appreciate your service and you being here today. I'm going to ask first if Dr. Wheeler would give us a brief update in terms of the flu season is going.
So there's three things that I want to talk about while they're trying to find the slides for me. The first is the respiratory virus season, which we're right in the middle of. The next is a brief update on congenital syphilis. And the last is a temporary emergent modification to part of the rules and regs. So flu and COVID numbers are still pretty high. Flu has been extremely high this year. The most common strain that's going around is an H1N1 type. There's also been a little bit of the Victoria. Those are matching up pretty well with the vaccines, but the numbers are still high. So it's not too late to get a flu vaccine. Tell all of your friends, because it will still continue to be a concern for the next little bit. The COVID numbers are not up at the level of the Delta or Omicron peaks like we had, but it's still higher than it had gotten down to. So it is still a concern as well. So the COVID updated vaccine for the year is still available. So if individuals haven't gotten that, they're still able to. And then RSV, the overall numbers of RSV are lower, but for those populations it impacts, so the infants and those over 65, there are options available for prevention. So that's still an option as well. We watch those numbers, but again, like I said, they're a little lower than the flu and the COVID. For the general population, it's a little bit less of a concern, although still concerning. As far as congenital syphilis goes, I think I mentioned to you guys last time we were watching the numbers, and one thing I was hopeful for was that the change in the rules and regs last time would allow for a decrease where we had been increasing pretty rapidly. And so for the current provisional data for 2023, we're at 55 cases. That will probably change as some more data comes in. The year before, we were 73. And so hopefully that is a true indication of the fact that the new testing and reporting requirements is actually doing some good. We've got a lot of other things that we're working on with that and around syphilis in general. But hopefully that's a good first step in the right direction. And then the last piece, while we're still looking, in the middle of December, we became made aware of a pretty significant shortage in erythromycin ointment for the eyes. So that is used for neonatal ocular prophylaxis for gonorrhea. So infants that are born to mothers who may be infected with gonorrhea, they pass through the birth canal, they can get infected and it can cause some pretty significant eye problems. And erythromycin ointment is really cheap and really easy. So pretty much every baby that gets delivered gets a little bit of ointment and no problems. But there's a shortage. And so there is a regulation that requires all providers attending a birth to do something about that. It's called ocular neonatorum or something. I don't know. Old words. Basically to do something to treat it, to do prophylaxis. And so we changed that rule and reg to allow for other options in times of shortages of the currently recommended antibiotic. And so basically what we did was say, if the healthcare facility is short on the recommended antibiotic, then reserve it for use in those at highest risk. So women who did not have prenatal care or who have a history of STIs or are at higher risk for gonorrhea. In instances where there is a shortage or an absence of supply, also consider testing, because when this rules and reg was written way back, testing was not easy, much easier now. And so do the testing at delivery and then make sure you treat quickly if it's positive. And then finally, CDC does have an alternate recommendation for prophylaxis in certain very high risk individuals. So the recommendation is to follow that. So that temporary emergent modification went through in December. We're watching the levels and it looks like the shortage may persist. So most likely we will do a more permanent modification to allow for some flexibility, and that would come up for you guys to review and take it. So that's all I have, and I guess we still don't have the slides, but if you have any questions, I'm happy to.
Any questions for Dr. Taylor?
Taylor, why don't you mention our current observations that are preliminary with syphilis?
Again, against what I just said, or?
Well, explain the trajectory and our game plan.
Sure. So like I mentioned, we had been going up pretty rapidly. This current year, we're at 55. For 2022, we were at 73. The year before that, it was also a number high. I don't remember what it is, but it's on the chart. I can send you guys later. So it had been pretty much rapidly increasing. And the first step is we've seen a drop off in this current 2023 numbers. Hopefully that is a true reflection of decreased congenital syphilis. Now, we do still have a pretty significant syphilis outbreak going on across the country, really, and congenital syphilis is a concern. And so we've got some other things that we're working on as far as decreasing syphilis in general, but also congenital syphilis. We're going to be working closely with our health equity folks and the community health workers to start doing local education to make sure that women of childbearing age know that they should actually go get tested. And if they get tested and are positive, that they actually should follow up for treatment. And then probably do some additional provider outreach to make sure that all healthcare providers that might interact with a pregnant woman know that it could be a concern. And so we've got a lot going on. This is the graph I'm talking about. So you see it's pretty rapid rise. And then we have that little drop off. So I'm hoping that that's the beginning of a rapid decrease. Time will tell. So, and just as a clarifying point on why this looks so weird, there was a change in between 2019 and 2020 to include probable cases so that we were getting a bigger scope of what the problem was so we could address it better. And so that's why there's that jump from 1 to 39. It's not a true reflection of changing cases. It's just the 2 and the 1 were confirmed. They met all of the criteria to be confirmed. And then we started watching the probables too, because they actually are cases. They just have a looser case definition.
Mr. Chairman, we are looking at all options in terms of syphilis intervention, and looking specifically at congenital syphilis, but we've got to get our overall numbers down so it's not spilling into the population of childbearing age. And I'm optimistic with this, but we will continue to push hard until we get back to where, we should be. And that's where we were in the 1990s.
Despite the trend down, that's still a very high number.
It is. It
Um,
is. And we're looking at every opportunity, including lessons learned in the pandemic of how do you approach behavior change? And looking at targeted messaging to impacted communities and making sure our messaging is how it needs to be and directed where it needs to go, and just being very purposeful in that work.
Very good. Dr. Taylor, thank you. Appreciate you. Any questions for Dr. Taylor before we let her escape? All right, very good. Thank you, Dr. Taylor.
And board members, you have part of your packet, our annual report. And this is becoming a much more meaningful document. It's very meaningful for me at year end, and I want it to be for you. And as we go forward, we will continue to shape this document into more than just satisfying a statutory assignment to being a good reference document for our work and for those who are interested. I would like to point out that we met all of our statutory deadlines this year, and we have caught up. Last year, the annual report was through 2020, which was unacceptable. This year, it's up through 2022. So we're looking at much more recent data and cumulative data, which is important for us. I think specifically to Young and her team for the good epidemiological work and statistical work that's represented here. And then Lauren Edgewood, our new director of communications, and I hope y'all will meet her today. And very, very excited about the good work she's doing in our communications
Stand up,
department.
let everybody see you. Welcome.
And Lauren came on duty and immediately was told, okay, annual reports due. And she not only worked with everybody and got it done, but did it exceedingly well. So I'm just gonna hit highlights for you as you study more deeply. But this is really our report card of where we are with population health. So the same old suspects continue to show up. The top 3 causes of death in Mississippi remain cardiovascular, malignancies, and accidents. And they're trending the wrong direction. And we see an awful lot of preventable death in those 3 categories, which helps to drive us to be the state with the highest rate of preventable death. And that trended up as well. That is a key indicator that I monitor. Maternal infant mortality trended the wrong direction. We know the pandemic had direct impact on the mortality of pregnant women, and we're going through those deaths right now from 2020 and 2021 with our mortality review work. Infants was surprising because we didn't have a lot of deaths related to COVID infection, but what we see is that there clearly was access issues in the midst of the pandemic for everybody. And we all remember you couldn't get screened for very much back in those days. And I think the babies maybe were having access to care issues. And I think, as we looked at cardiovascular deaths trending up and cancer deaths trending up through the pandemic years, I think some of that was access to care issues. We'll know more as we study the pandemic further going forward. But let me share some good news. How about it? All right. Dr. Sutton's team continues to work on teen pregnancy issues, and we continue to see positive results that, when you look at the last 5 years, the trend is down. It's not drastic, but it's going in the right direction. Sometimes we'll flatten. Some years it may bump a little bit, but drop back down. But I'm encouraged with the teen birth trend, and that we need to continue to improve that. Dr. Meg Pearson, Meg, wave. Her department's good work with our opioid grants, and specifically the naltrexone distribution programs that have been extremely effective, and working hard with education upstream, especially with high schoolers and college age students about the dangers of fentanyl, and our partnership with Department of Mental Health and Department of Public Safety, all together working hard. Opioid deaths were down 10% in 2022. And as an addiction doctor, that is huge. It's reduction in deaths, but it's not big reduction in events. So we're rescuing people, but we've got to get to the point where they're not dying in the first place. So that's one data point that it's a positive. I wanted to point out to you, the report shows that our very effective TB program continues to demonstrate good results. The trends are stable, which I was nervous about the pandemic, maybe destabilizing our TB trends. But they are significantly below the national rate. So we, are doing, and that's a program with virtually no funding. We do a patchwork to keep TB going. This one is amazing. Our obesity rates continue to trend down. And I remember getting the report, we went from like number 1, number 2, worst in the nation, down to 5th. And my first thought, well, finally people are doing worse than we are. But it actually is both. So there's states trending the wrong direction and us trending positively. And this is a trend. And so seeing the obesity rates dropping, again, that falls under Dr. Sutton's team's area. And these are just demonstrating that evidence-based population health programs work when we fund them. And when we have the funding and the resources to employ these programs, they work. And I'm very, very proud of my team. Jennifer here, Dr. Taylor, HIV rates continue to trend in the right direction. And so it's going from scary numbers back before 2017 to now, just easing down in the right direction, even through the pandemic, continue to ease down. So our Ryan White HIV program work is paying good dividends. Any questions for that, Mr. Chairman?
Any questions?
Okay. Just quickly, I've shared before that we're in the midst of rebuilding the workforce coming out of the pandemic response. And I've shared with you that we are rebuilding not just the workforce, but really the agency in so many ways in terms of how we operate, really trying to apply private sector business principles to as much as we can so that we're efficient, bring overhead down, and generate as much of our own funding as we can that's appropriate in a sustainable fashion. And because of our revenue cycle work, Dr. Young's team, working with field services, Dr. Sutton's team, we had a lot of positive trends this year in clinical operations. Encounter rates up almost 12%. Very important for sustainability. Our new patient visits were over 11% increase. And we had seen a worrisome trend that has now been reversed, because all of us who have clinical private practice experience know new patients are extremely important for your systems. It is for us as well. And telehealth continues to grow. We had a 101% increase over last year, which was a very small number. But I'm glad that we have a 100% increase over a small number rather than a 10% increase over a small number. But our telehealth programs are growing and maturing, and the numbers are increasing. And a good benefit of that is our no-show rates have plummeted. So we have really worked hard on the no-show rates, and our transportation program has helped that, and the telehealth program has helped that. And so billing, collections, revenue generation are all moving in the right direction. Still a lot of work to do. I'm very proud. We have our workforce development office open after our budget cuts in 2017, when, we were just trying to keep operations going in the field. So things like leadership development, workforce development had to go away. But now we are standing those programs back up. And so we have more effective recruitment, more effective retention, because turnover is very expensive. And then cultivating our leadership base within our own to be able to move up the ranks to serve the needs of the agency and population health. Jennifer Bowler running that office. We're off to a very good start. And a byproduct of that work, we now have our academic affairs office open and operational. Dr. Anthony, Anna has been working very hard in that space, and we're already trying to mature our academic relationships that we've had for several reasons, primarily to generate a workforce pipeline for us that's stable as we help to educate the next generation of public health workers. Secondly, the more we can expose healthcare professionals to public health, the better they understand what we do. And so even if nurses rotate through, or medical students rotate through, or residents rotate through and have no interest in working for the health department, they'll know what the health department does, and we can utilize our resources. And then we're working to build internships and fellowships and residencies and all to improve the workforce for public health. All right, an exciting thing I want to announce to you. You know that we've had an Office of Rural Health for quite a while. It's one of our statutory mandates. And it has not gotten a lot of attention, has not had very good funding, has had a very active, hardworking team there. But really looking at the challenges of my tenure, these 17 months, it's been rural health challenge one after another. And then the challenges in rural Mississippi are just very different, as we all know. And so the Office of Rural Health is going to be invested in with our workforce development money. And I have hired Dr. Jennifer Golson to be the first full director of what I hope will grow into the Center for the Study of Rural Health within the health department, and be a center of excellence, academic work, data collection, and partnerships with all our community stakeholders in rural Mississippi, and really work to grow that office into a robust program where whenever we're facing challenges in rural health in Mississippi, it'll be a pivot point for folks to go to get the information they need, and resource education they need, and hopefully some resource deployment. There's a lot of HRSA money coming out for rural health. There's CDC now has an Office of Rural Health that's maturing. I just see more and more funding coming this way. Dr. Golson knows that I'm making I'm making an investment strategically here. This is seed money, not sustainable money. So this is going to be an office that has to get to work and cultivate that grant funding. And but we're really following the success model of Office of Workforce Development. Plan for us to have an advisory council putting input into that area, and then build it out in a way that will be sustainable. Any questions? And also the legislature had passed really a model for what an Office of Rural Health should be. It was not funded, but I'm taking the statutory language as a skeleton as we build it out, and I'm pulling the funding as best I can and hoping that our friends at the Capitol will help us in that regard.
It's exciting. What questions? Any questions about the rural of rural health? and the academic affairs is long needed. And I think, for college students and for medical students and for healthcare professionals, there's a lot that we can learn, and it's a great way to get our workforce rolling.
Yes, sir.
So that's a great thing. And with the developing residency programs, they ought to have a rotation here every single one.
So we have formal relationships with Gulfport Family Medicine Residency and one that's developing for the program, Family Medicine Program in Meridian. But we are happy to partner with any of the community-based residency programs to provide the access to public health. And if you think about it, when you're in a busy county health department, that's the place where you see, STI work, family planning work, maternal infant work, TB, immunizations, all concentrated together. And it's in a lot of good clinical teaching opportunities that will help programs take advantage of. We've had good partnership development with Jackson State, USM, UMMC already, UMC School of Nursing, and their PA program. And so a lot of interest among academic institutions to partner with us. I think it will be mutually beneficial. And then just quickly, our transportation to health program continues to grow. And I think we had 133 visits in the first 2 months, and the word's not even out that well. So we continue to promote the program. The need is obvious, and we're seeing even more need. People calling, want to know if we can help them get to their doctor or to UMC or to wherever. And right now, the demonstration project is looking at bringing folks to the health department. And so, and the demonstration project will show us where the holes are, where we need more Uber coverage, and now we have other partners that are coming to the table, other state agencies wanting to get involved, other companies wanting to get involved. So I'm very pleased with how that program is developing. And the Know Your Numbers project, where we started screening for blood pressures and blood sugars in the county health departments for free. No appointment, just come in, Stein Encounter, just come in, and our folks will check your sugar, check your pressure. Has been very impactful. We have done over 3,000 screenings, and just in September, and the numbers are climbing. And the stories I'm hearing are just demonstrate the need. We had a family in the Delta that came into the health department for other services, and a very attentive clerk that says, "Why are you waiting? Would you like your blood pressure and sugar checked?" And they did the whole family, and we found a 13-year-old who had hypertension, and we found 16-year-old brother had unrecognized diabetes. And then, of course, our team got them placed in a medical home. And the biggest thing I was wanting to see with the screening program was, what would we see all over the state? So we're tracking those numbers, and we'll have region-specific numbers that we can look at together. But we're seeing some impact for individuals, but we got to move it to a population. But I'm grateful for improvements for individuals at this point. And then finally, we have our first mobile unit in, and it is being wrapped now. So it has all the appropriate MSDH logos. It's going to have a disclaimer: this unit was not bought with any state general funds on it. And what we're doing with it is whatever we need to do with it. So it's not assigned to a program or a department. It is an agency resource, and we plan for it to be a community resource. We'll be sending it out in support of community health screens. We are going to use it for screening for HIV, STD, and areas where we need to make a little bit deeper dive. Any disaster response, we are there, but now the mobile unit will be there, which you're at the next board meeting, we'll have it wrapped and ready for you to look at. I think you'll be very, very pleased. And as an old clinician, I can think of 1,000 ways to use it. And the old units we had were worn out from use, and we will eventually have 3. We have the grant funding to do it. To be deployed, probably one to the Delta, one in North Central, and one in the South. But they'll be able to go wherever they need to go. And
So it's a medical clinic.
it is a mobile unit with 2 examination rooms in it. And it's as large as it can be without requiring a CDL. So, you know, even I could drive it, but don't worry, I won't. But you know, it can be a resource, and anyway, it basically would be a mobile platform for us to push a program wherever we need to. And I mean, we're even talking about the possibility of doing an endoscopy suite in one, and making screening for gastrointestinal cancers, which is one of our big preventable deaths, you know, for the uninsured available. There's just all kind of possibilities. I told the team to, you know, just dream big with them, and they cannot sit idle. They have to, you know, be put to good use. They will. And I've already had conversations with mayors that really are wanting us to come and support of some of the health screening work they want to do. And Mr. Chairman, that is all I have. Thank you.
All right, what questions do we have for Dr. Ed? Yes.
2, or actually 3. 1, can you give us an update on what's happening with the cannabis lab? Because we don't have a cannabis committee report later, so just if you get an update. And then second, before we go to the consent agenda, can we get an update on the status of the hospital grant program? Because I know there's a line item on there about that. And then third, on the obesity numbers, which is great news going down, it looked like there was a big jump from 15 to 19. And we're still like 10% higher than we were in 2015. It didn't look like there was a corresponding jump nationally. Was that a data collection issue, or is there something that happened that made Mississippi fatter between 2015 and 2019? Like what's
Yeah, a lot was happening to make us fatter during those years. And, you know, so now we've seen the trend reversing, where in many other, especially southeastern states, the trend is going the wrong way.
what was going on? I mean, why it looked like it was relatively static for a while. Why is there something that why such a significant jump? I mean, if maybe it's unknowable, just curious.
I don't have a specific answer outside of especially rural Mississippi, the easiest access for food or high calorie foods, oftentimes with low nutritional value, and then, you know, an awful lot of drinking sugary drinks, and then increasingly sedentary population. Dorothy, do you have anything specific? You know, Victor, that's about the time we really started pushing the obesity partnerships and programs in Mississippi. If you see the trend, there's something that's happened here that needs to happen to some other states. And, you know, I was very thankful to see it. I mean, we're not going to claim credit for all of it, but I sure know our preventive health folks have been working hard in that space. Diabetes and obesity work kind of go hand in hand with us. And I was actually fairly surprised when I saw it turn as quickly as it did. And it could jump up again next year.
Cannabis.
Canada, you all know that we have an investigation going. We had 2 cannabis labs that were operational, and one of them that had the majority of the product tested through them to the dispensaries. We found just some reporting concerns, and it was level high enough to cause us to act. And so but all the lots that tested through them in that time period in quarantine. So there's not a recall. The product is still there, but it's being, you know, retested in a statistically valid way to see to make sure that the concerns we were possibly seeing were not a danger to the public. But that investigation is ongoing. Testing continues. We have a new lab online now, so we're back to 2 labs. Testing, we'll have a 3rd very soon. And product flow, was bottled up, but it'll start loosening up. And Chris, Laura, we anticipate releasing some product this week.
On Friday.
On Friday. The product that's being tested this week that was deemed safe will be released for sale by this Friday. There's still a lot more to test though. And the 3rd.
It's just how many, since there's, I don't want to pull an item off the consent
Yeah,
agenda,
that,
but just, it's sort of brief update on the grant program. We had a lot of conversations about it in the past.
so I'm gonna let Chris give you the specific numbers, but a lot of positive news in terms of eligibility, a lot of frustrating news in terms of process to demonstrate compliance to push the money out because of the ARPA issues. But Chris, give a quick numbers update.
Sure. And you'll see actually included in your consent agenda is the final approval of a regulation that we use to actually expand eligibility for that program. We moved into a financial review that would include a quarterly basis and take us through 2023. So we've got 103 applicants right now. We have dispersed funds to 17 of those applicants. We estimate that we're going to spend about $65.5 million on the program. And then we'll have some remaining decisions to be made by the legislature about how they intend to spend the remaining balance from the hospital sustainability program.
Do you think that there'll be more than 17, or is it just, is that 17 into 65 is to 17?
17 out of 65 funds have already been dispersed, and I anticipate the rest will be eligible. We'll probably have about 10 that are ineligible.
And we're just very communicating with leadership of, what we're seeing with the ones we just can't get eligible that clearly have need, but we can't get them ARPA compliant.
Sure.
And,
I want to make sure Chris understood. So you said that 103 applicants, 17 have been dispersed.
Yes.
And that 17 has received 65.5 million.
No, 65.5 million is what we expect the
What-
total
total,
payout's going to
okay.
be.
You
Yes,
think that, and that'll ultimately be like 93 of the 103, will
likely.
one total get 65 million?
That's
Okay.
what we estimate. Yes, I'm sorry.
No, it wasn't you, it was me. I just couldn't.
the regulatory action before y'all related to the grant is for you to approve or deny or modify our emergency regulation that allows us to do expanded eligibility. And that's been in place until this meeting, and that's before y'all to make final if you so choose. Thanks.
Good questions, Mr. Perry. Any other questions for Dr. Randy?
This may be out of order. Do you know how many exemptions from the childhood vaccination that we've granted?
Yes, too many. I'm gonna let Dr.
As far as I'm concerned, one is too many, but
I'll let Dr. Taylor give you the-
medically necessary.
Dr. Taylor has the benefit of that job.
Yes, sir. So for the religious exemptions, we're probably just over 2,300 at this point. I don't have the exact number. These are scattered across the state. And just for perspective, we had been having about 400 to 500 medical exemptions per year. Some of those exemptions are being requested by individuals who are not actually in school at this point. So we have some more data to look at to find out exactly what the impact will be. But as of right now, we've had and processed about 2,300, maybe a little bit more.
Do we know where those are in the state, like where the clusters may be?
They're all over, and we can look at that. I could guess, but I would just be guessing if I tried to guess right now. So I will look and I can get that back to you.
2,300 kids, or is that 2,300 vaccines?
It's kids.
Kids. So, and typically, most of the vaccines are happening in is it fair to say that's 2,300 of roughly 35,000 or so, plus or minus cohort, or is it 2,300 of 70,000? Like what age range are we?
Oh, so it's from childcare age up to 18, I guess. And we're seeing it across the gamut as far as age goes. We've had some within their first year that are coming in to do it.
Where I was going with the question is, do we think that that number will decline because there'll be, if you're already in that cohort, you've gotten your exemption, whereas this now it's new live births coming in. I mean,
Right, so I think most likely there was a little bit of a backlog of individuals who were interested in this that have all gotten it during this time period. And then as we move forward, it'll be new children being born, new children moving to the state and things of that sort. So I think it'll stabilize.
And, so that total number is not a concern for the entire population of the state. But there will be pockets. So those will be pockets of concern where there are more children with exemptions than, other areas. And we'll have to watch for what happened in Pennsylvania with the recent measles outbreak there. It's something that's now on our to-do list that has not been on our to-do list for 40 years. And we'll just have to be ready if and when it happens.
Good question, Mr. Moody. All right, anything else?
I had a question about the mobile units. Who are when they can just be dispersed to anywhere, are there certain specific medical people that are dispersed with it, or is that determined on the location of where the mobile unit is dispersed?
It'll be staffed by health department personnel, and it'll depend on what it's going to do. So, if we'd had the mobile unit when the Rolling Fork tornado hit, our team that went and was there would have taken the mobile unit, and it would immediately have been available instead of them having to run the ER at Carlton like they had to inside the armory. They would have had 2 exam rooms that provided great privacy, state-of-the-art equipment. And then if we need to augment that staffing with health department nurses, we can. And then also, if we're sending it out for screening, for know your number screening, it'll have the right personnel. For STI, HIV screening, it'll have that type of personnel, and some of it, may be going to help people with enrollment issues for Medicaid and Marketplace. I mean, I've told the staff, think broadly how we can utilize it for the benefit of our people.
I've got a follow-up question to what Beth was asking, and that is it sounds like that this is a multi-use system, and I'm assuming that would in part at least be used for disaster management with the ability, and maybe not even just one vehicle, but perhaps 2 or 3.
All 3 will be multi-purpose, and they'll be stationed strategically in parts of the state, but they'll be able to go where they need to go. And we'll be, storing them indoors, maintained, well protected, and but it's not going. These aren't going to be, disaster response vehicles. They'll be, agency response vehicles that can be used for that whole laundry list. And I think it would. I mean, we will use them every time there's a disaster, but there's a whole lot more we can do with them as well. And so if you have ideas, share them with me. We'll give it a try. There are a lot of mobile units around the state with our NQHC partners, but they're restricted to their district, and they use theirs a lot. Ours will be able to be used anywhere in the state.
All right, any other questions? If not, Sharon Dowdy, would you,
Mine is very brief. Have a prepared presentation. Since the legislature is just now back in session, we don't really know how our budget's going to look. So Do you have any questions for me? I can tell you, we have cash. That's the positive thing.
Everything looks the way it did last board meeting.
Yes, the thing. So, and our spending is just like I expect it to be, so nothing's out of the ordinary. If you have any specific questions, I'll have more at the next meeting after the sessions go on in the legislature.
Do you expect anything that to impact us differently from our budget standpoint?
I do not, and we're hoping, hopeful they'll give us the money that we're requesting from general funds. I don't know if Dr. Edney has shared what he is asking for, money to help our lowest paid employees. We're asking for money for that. And then some money just to help, community-based program initiatives. That's really the only thing.
Thanks. Any questions? Sharon?
Would any of our renovation money have to come out of general, is it gonna be a bond bill or will it just be covered by appropriation?
All will depend on how the legislature wants to do it. They have not issued bonds the last few years. They have, the last time they gave DFA ARPA money to help us. And they've used some capital expense money. So it's all going to depend how they decide to take it. DFA will be the one that will get the money for us most likely. We're going to fight with them to try to get it, but hopefully. We're hoping that the phase is supposed to start. They tell me, I've been there before, DFA will take. We're waiting for it to start still. Hopefully in the next few months, they'll start the first part of it.
Thank you.
Mhm.
Very good. Thank you. All right, next item on the agenda is our consent agenda. We've already had some explanation of item 1. Is there a motion to approve our consent agenda? Or motion and a second, and this is for items 1, 2, 3. All in favor, say aye. Any opposed? Excellent, it passes. Committee reports. Dr. Cheney, will you give us a report on maternal infant health?
Sure. The Maternal Infant Health Committee met November the 27th via Zoom. We're still trying to fully grasp the importance and just the process of our role in maternal health in the state of Mississippi. Currently, our major initiative is the development of the maternal system of care, and that's being done in conjunction with the Mississippi Healthcare Alliance. I think it should be noted that in the list of recommendations from the Mississippi Maternal Mortality Review Committee, in their most recent report, it was stated of the need for a coordinated response system is needed from the point of the 911 call about the fastest method of transport, the closest capable location, and the needed expertise to support local providers. And that's exactly what we're trying to do with the system of care. The Mississippi Healthcare Alliance, along with Jim Craig and others, bring a vast knowledge and experience through their work with the other systems of care in Mississippi, such as STEMI and stroke and trauma. And in that meeting, Dr. Edney gave us an update on the maternal system of care development. And given the success of in the other areas, the maternal system of care will follow the same roadmap used in these other areas. Dr. Edney and I met with some representatives of Mississippi ACOG in an effort to build consensus with stakeholders. They emphasized the need to include both reasonable access to prenatal care and early access to prenatal care as guiding principles. They also believe that an advisory group of physicians with broad representation across the state will be useful. We talked a lot about data, and the committee discussed just how to access data to inform our recommendations. In speaking with Jim Craig, he will be asking for some other states who are in that system of care, have experience with maternal systems of care for their recommendations on data sets. And because we're really not aware of a current single one-stop shopping, single source for the types of data we need to inform our decisions. And Dr. Anthony suggested that we consider ways to get the message out to the general population of the importance of this work that we're doing.
Excellent. Any questions for Dr. Cheney? Good. And that committee will probably be meeting in the next several weeks.
Yeah.
All right. Dr. Carlton, would you give us a presentation on emergency medical services?
Sure. We had our inaugural meeting via Zoom on January the 2nd and had a lengthy agenda, 3 pages. I'm going to spare going through all of that with you for now. What the committee has done, though, is referred what we recommended on to EMS Advisory Council, which is meeting this Friday. So once they meet and make some decisions about how they want to proceed with a lot of this, we'll bring it back to the board and then talk about it. I just want to emphasize that the agenda was not prepared solely by me. I did it in consultation with a number of people from the EMS community. So hopefully, once we get the feedback from EMS Advisory, we'll probably, we could even potentially have an emergency or special board meeting just to approve it, because there are a lot of these items that I would like to see us adopt as soon as possible. That'll obviously be up to the chair, but at any rate, a fairly busy agenda. And again, we'll talk about it more in our next meeting.
Excellent work. Very good. All right. The next item on the agenda is new business. Is there any new business that any board member would like to bring forward? If not, under old business, we are going to get an update on the state health plan from HMA. Caprice Knapp, are you close by? All right. She's going to present an update. Very glad you're here, and we appreciate the great work you're doing for the board and the department in our state.
So thank you very much, Chair Lampton. And first of all, I just want to introduce myself. My name is Caprice Knapp. I'm a principal at Health Management Associates. We have a team that we've been working with, the Department of Health. That includes myself and Jack Meyer. We're both health economists. Chris Wilkes, who has a PhD in public health, and then we have an epidemiologist on our team, Anissa Lambertino, that we've been working with, and Jacob Briscoe as well. Appreciate the time of Dr. Edney's team and staff. They are fantastic, from your licensure group, Melissa Parker, all the way down to your CON staff, Tanika Hardy and Deja and Rachel, a fantastic group. And of course, Chris Adcock, we thank you so much for helping herald this project through. In front of you, you should have a printed version of the executive summary. And I will go through this just briefly. Certainly don't want to go through every page, and then I have my laptop here because I have, if there's more information you want, or if I need to refer back to some of the more granular data. So again, we were procured through the Mississippi Department of Health to take a look at your state health plan. And you all, of course, know that there's 2 major sections of that plan. The first part of the plan really looks at, in chapter 1, really looks at what does your health system look like, talks about provider availability, and some of the priorities that you all have as a state. And we just heard Dr. Cheney talk about maternal and child health, for sure, that's in there. And then the last chapters 2 to 7 of the state health plan really is driven by your certificate of need program. And it outlines your services that you have under certificate of need, provides some data, some population projections. And you can see for acute care hospitals, skilled nursing facilities, behavioral health services, and all the way down to comprehensive medical rehabilitation services. We first took a look for you to see, where you sit in terms of other states. There are about 35 states that have functioning certificate of need programs. This used to be a federal requirement in the 70s, and that went away, but about 35 states have still kept their certificate of need program. some of which are very robust and have lots of services, and others of which only have a couple of services. This is an area, as you all know, that's hotly debated. We took a look at legislation that has been debated last session, and sure that will come up in states in this upcoming session. Ideas from taking a look at streamlining this process to eliminating this process, and also thinking about adding or removing services. On page 5, we also took a look at the academic literature. We identified 45 different peer-reviewed studies. And I'm not going to say we conducted a full meta-analysis of those, but we extracted data using standards that you would for systematic review and meta-analyses. And really, as you look at those publications, and we're happy to provide that reference list to you all, there really wasn't conclusive evidence one way or the other about whether certificate of need programs have positive, negative, or no impact. Did email back and forth with Dr. Vivian Ho. She's at Baylor. And she's done what I would consider some of the most seminal work in this area. And her conclusions were under number 3. They did a very large study of Medicare claims data over a long history of time and looked at that to see, were there really significant changes in terms of cost and utilization if you looked at states that had a CON program versus states that did not. Page 6 looks at over the last 7 years, the applications that have been submitted to your state certificate of need program. And we have more granular information here on the types, but in general, you're not seeing, you've got a high approval rate. That's pretty common across states. And what we hear from most states is when we spoke with them is most people are not going to submit a certificate of need application unless they think they've met the requirements. But again, you've got a high approval rate. Your number of applications and approvals is lower than states in your region, and I'll pull out some of that data when we get there. But again, you can see by year over the last 7 years. The next piece of what we did was really to reach out and get information and opinions from as many people as possible. We know that the Certificate of Need program and the state health plan are really important to your stakeholders, and wanted to make sure that people were represented. We did a couple of things here. We did a public opinion survey that was launched online. We had 90 responses. We actually had quite a few more than 90 responses. And then I got a whole education about how you can check that bots did not, your online survey. I didn't even know that this existed. So we culled through this with our software to make sure you're getting real people who are answering this. We had about 90 completed questionnaires. We did 31 in-depth one-on-one interviews with stakeholders, and you can see some of the list there that we did. And Anissa Lambertino took a look at your data, and I'll review some of the results there. We've got rich in data here in terms of publicly available data sets and certainly within the department. And then again, we did this analysis of comparing you to peer states, and you can see on page 8 the peer states that we compared you to. These were presented to the staff in terms of looking at demographics, in terms of looking at the way the health system is set up. And you can see the list on page 8 of the pieces we extracted for those peer states. So we wanted to give you some information about how Mississippi compares in each of these parameters. Okay, so starting on page 9, very, very high level information from the public opinion survey and from the key informant interviews in terms of the strengths and weaknesses of the certificate of need chapters that are in the state health plan. You can see that some of the pieces that were called out by the respondents, the strengths in terms of, limits. The program limits profiteering and oversupply. It ensures a more equitable distribution of services. And it's agnostic to factors actors that might have an interest that are just about revenue and revenue maximization. Weaknesses, there was, we saw a number of comments about data, looking at outdated and unreliable, comments about the formulas in the report, and we'll expand on those in the recommendation section. Strengths and weaknesses, this goes to chapter 1 about the state health plan. Strengths, we're really calling out the systems of care. We heard conversation this morning or this afternoon about stroke and some of those areas where you all have made a lot of progress in systems of care, and that was brought out. Your ability to react in a crisis, whether that's tornadoes or the recent pandemic, good interagency relationships, and a lot of willing providers and facilities that, you know, really want to serve this population and make sure that your health and well-being of your citizens are of most importance to them. Weaknesses of the system, comments about payment rates, some of those directed towards not just Medicaid, but also on the commercial side, workforce issues, concerns there across the board, distribution of services across the state, and lack of having a single healthcare authority to help sort of drive this coordination. I'm not going to go through on page 9, this blue diagram, because again, we were commissioned to ask questions about the state health plan and the state health plan chapters, but you can see some of the policy recommendations that people brought up in relation to their comments about the strengths and weaknesses of the Certificate of Need program and also the Mississippi health system. Okay, moving on to page 10 and 11. These were really from a public opinion survey. You can see that across the board, we said, you know, what are some things about what's in the state health plan that you really want to focus on changing? We looked at average scores, and again, there's that actual data collected and presented. That seemed to be the one area that people look most concerned about. And that is in alignment with what we heard for the key informant interviews as well. But also some of the other areas in terms of formulas and the types of services that are included. Table 3, this is again, as it relates to chapter 1, what are the top 5 most useful information or data elements that you want in a new state health plan? And you can see we've ranked those for you. It goes on from page 10 to page 11. But really, again, wanting more data visualization, that was the #1 response, and more public health data. Our epidemiology analysis that Anissa Lambertino did for us, we can actually look at, we have 2 maps to present to you on pages 13 and 14. And really the idea behind those maps on page 13 is we were looking at your CON application approvals. We looked at them by county, and then we compared those with life expectancy by county. And you can see in the counties with the dark blue categories, those are areas where you've had the highest CON application approvals and the highest life expectancy. And so, of course, you've got Hinds County in the middle, that's dark blue. And then you have a number of counties that are colorless. And again, those would be areas where there's low life expectancy and lower numbers of certificate of need applications. On page 14, we were asked to repeat that process, but looking at it more from a population density or a rural versus urban approach. And you can see, again, very similar results. We picked up a couple more dark blue counties there, but in general, you have areas where you have negative population growth or stagnant growth. That's where you're seeing less certificate of need application approvals. Okay, moving on to page 15, and then I'll move into some of the recommendations. Again, we did a deep dive analysis on these peer states that we identified and worked with the Department of Health staff. You can see a few of the parameters that we highlighted. I'm certainly happy to provide information on every one of the parameters, but really tried to pull out the ones that seem to show key differences. But the second row, I think, is really interesting. We looked at facilities that are requiring a certificate of need application. Arkansas and Louisiana do not require those for hospitals. And then there are some facilities or services that are covered in other states, but not covered in Mississippi, and specifically hospice and pediatric and adult day centers. In terms of exemptions, Alabama has an interesting concept whereby they don't want to necessarily always approve certificate of need for places where there's low occupancy rate. They want to be able to make sure they're awarding facilities that people want to go to and that have high occupancy rates as well. So you can see they have an exemption around a 95% occupancy rate. Louisiana has exemptions for, and the way I interpret this is emergencies. Something has happened, there's been a fire, there's been a flood. You don't need to come through us and do a whole certificate of need process in order to renovate or to rebuild. And then you can see Tennessee has an exemption for counties that are economically distressed and have no hospital. Interestingly enough, though, we learned from Tennessee that those economically distressed counties are designated by the legislature and they could change. So it could be that one year you have 5 counties that get that designation, and then a second year you come in and maybe 2 of those lose that designation. So it'll be interesting to see how that unfolds in Tennessee, to see which counties over time continue to get these exemptions. Interesting on transparency that you all post your approvals and denials online. The majority of states that we talk to do not. And my intuition there is sometimes we heard comments about if we get approvals online, then people might present an opposition, not because they necessarily think that facility or those services shouldn't be provided, but they need time in order to think about how that's going to impact the incumbent business or maybe how you might respond. So there could be a reason why those aren't published online in terms of making sure that some of those conversations happen behind, in terms of the approval process. But you all have a very transparent process, and I understand because you have your hearings as well. That's a very transparent process, and everyone knows what's happening at all times. And then finally, want to make a note that almost every state except your state supports their certificate of need staff and program with a mix of funds, not just application fees, and certainly able to, and as we get to Tennessee in the next couple of pages, can talk about some more things that they're able to do. Formulas, this is one thing that Alabama was able to do, again, because they receive funds not just from general fund or not just from application fees, but from general funds. They were able to do over the last 5 to 7 years a quite in-depth study of their formulas. They changed their formula approach from a population standard to a utilization standard. Again, they're really interested in occupancy rates. As opposed to, we have a population ratio, we multiply that, and we tell you how many beds we think you should. So moving on in the last couple of pages, just to sum up what we heard and what we saw in the data. The first point is to say that there's really, you can see that there's a need for 2 separate documents. You have chapter 1, which is about let's describe our health system. Let's say where some of the gaps are, but let's also highlight what we're good about. People really wanted that more fleshed out. And also some more highlights on the priority areas that Dr. Chaney talked about, but also workforce and some of the trends that we're seeing in healthcare. And then separate from that the chapters that are related to the certificate of need process and the services. Again, there was a discussion, many people brought this up, that there's no one single authority to help guide some of that planning. Certainly, you all have the statutory authority to have the state health plan, but for example, there needed to be a coordinated approach for behavioral health services. That's an interagency discussion and it's unclear what the authority is. In other states, they have healthcare task force, healthcare authority, bodies like that, which help drive and coordinate planning across the state. Here again is the example of Tennessee. Happy to provide some of those links to you all, but just their chapter 1, really fantastic. It's brief, only 24 pages, but it has dashboards in there. Every year there's a plan to update that. And it really is a collaborative process where everybody in the single standalone task force is able to keep up to date with the progress that they're making. And then the only other point is, in chapter 1, you could capture some of those trends that are happening in healthcare. So we heard a lot about movement from inpatient to outpatient services on the hospital side, on the nursing home side, certainly even in the developmental disabilities, where there's this push and trend to pull people out of institutions and facilities back into homes and communities. And so, that could be a good place to discuss that. From where the state is, and also in terms of workforce development. Using certificate of need application data to inform changes. What we noticed is in terms of the applications that have come through, the highest number of applications were around hospitals, but not necessarily to go and build a hospital, but to add on services within the hospital or equipment. Very few, if almost none in the last 7 years, were there applications to build physical buildings, whether that's nursing homes, which obviously we have the moratorium, PRTFs, hospitals, but it really was about those services. And specifically those services where there's that tension between the services can be provided in a hospital outpatient facility versus a standalone facility that physicians, for example, might develop and implement. ESRD services, ambulatory surgical centers, and equipment. So that's really where most of that action is taking place. And then on the nursing home side and on the PRTF, there was renovations or maybe beds being moved and things like that. But because again, you have the moratorium, less action in that space. I want to make a point about abeyance. Certainly saw, and I'll talk a little bit about this with Illinois in a minute. Interesting that, the abeyance piece came up. So this is the idea that we have beds, and we call this bed layaway in the states that I've worked in. The idea that facilities that aren't using beds can store them temporarily or even lease them. And that could be a good thing, or it could have some unintended consequences in terms of being able to regulate the supply of those beds. So just examples of what we saw in other states when we talked to them, instead of having a leasing process, could you take a look at your layaway or your abeyance process and put a cap on the number of years in which those beds can be in abeyance? Is the value of those, is leasing the appropriate way to look at them, or should the state be able to put a value on them? So ideas there about how you could look at the framework of abeyance. Redistribution of services and beds. Again, this is the idea that we've seen in a lot of states, which is we have a lot of beds, but they're not necessarily in the right places. And so, could there be a discussion about how to shift some of those beds and those services to those areas in the maps that we saw that were the colorless part? Clearly that has to do with economic incentives and workforce ability, but a couple of things that we pulled out from states. So Illinois, for example, created a nursing home conversion task force. This is a group that met for at least 5 years that really focused on this, shifting those beds because they had a moratorium as well. So shifting those beds to home and community-based beds, day centers, respite. So what can we do with some of the beds in those facilities? And also shifting nursing facility beds to parts of the state where there weren't enough. We talked before about the rural emergency hospital rules that came out by Medicare in January of 2023. That's an opportunity to take a look at hospitals and look at conversions there. And those REH hospitals, typically EDs, observation units, labs, et cetera. So ideas there and thinking about how to redistribute those services. Hub and spoke models, we also pointed that out, that came up as well. You know, we don't need a trauma center in every single county and state. You know, could you set it up in terms of tertiary services and regions? And I think you have some of that already going anyway. But thinking about then for primary services, certainly everybody should have access to those. So could there be some shifts there in terms of a hub and spoke model? Data accuracy, we've talked about. Lots of recommendations that we got from the peer states where they do interim data collections, single one-page forms. And then that data gets updated and made available so that they're not doing the entire CON application process, but they're doing a quick form that can come through licensure or that could come through your CON program. And really, again, wanting to make sure that the data is accurate and available and making sure we're collecting the right data. So it's not just the beds, but we talked about it's the staffed beds, right? And it's the type of beds. Accountability and transparency. Once the certificate of need application is approved, it's unclear that there's the ability on the back end to come back and check, right? So did the facility do what they said they were going to do? So just is that a discussion that you all want to have, even if that's a desk review or some type of process to say, you know, we made a commitment to this community. We are going to provide these services and what that might look like. Again, we talked about exemptions in the areas where Mississippi is significantly behind. You know, could you consider exemptions there from the CON process? Again, the psychiatric residential treatment facilities, the behavioral health services, that would be an area where to have some discussion. For PRTFs, the only movement we saw in the last 7 years was, I think they took beds from a Gulf Coast facility and moved them to Jackson, but there weren't any applications to add more beds for those facilities. Modifying some of the criteria, again, that's about the formulas and thinking about could you make this a more streamlined process? Your staff does a fantastic job, and I'm sure through the board as well. You take feedback from everybody in this process. It's really an open and transparent process, and a lot of that work has been done. And then finally, thinking about appropriately funding the staff who run these programs. So one of the states did say to us, it's like a balloon, right? And so if you say we're going to exempt this type of facility from the certificate of need group, you then have to push and fund the licensure group, right? Because someone takes responsibility for the oversight of those facilities and those services. But thinking about, is the funding in this program sustainable? Are you getting what you need? And then also, thinking about if you want to include some of these new vision that people have brought up, if you want to revise formulas, if you want to separate these documents, coming up with a plan about how to do that. So I'll stop there. And again, just want to say thank you and really appreciate, and you can see the last quote we have on the last page, which I thought was a great one. Really appreciate everyone's time and dedication to this program. It was very clear to us that people care very deeply about the health system of the state.
All right, what questions do we have?
Reese, thank you very much for working with it. And we've been talking about this a lot as a board, and we had a lot of conversations as a board with you, your team, whatever it was about a month ago. If the last thing you said about the balloon, say that the legislature decides to exempt certain facilities for CON, for states that don't do that, that have similar exemptions, clearly they continue to regulate them for safety and other concerns. Is that typically done through their licensure groups as well? There are certain models that we should point out. If the board decides to suggest to the legislature that, for example, services related to maternal and infant care or psychiatric services should be exempt, what are the issues that we should be thinking about that maybe other states have learned in terms of regulating the safety and quality and whatnot? How you separate the CON from the licensure?
Oh, it's a great question. I think that Arkansas and Louisiana example are great ones to look to because again, they don't have certificate of need for hospitals. Everyone clearly on the facility side has to go through life and safety and that's with Melissa Parker's group. You could think about as you make that shift, right? If you decide to remove or even lessen certificate of need on some of the services, go back and take a look at licensure. You know, do you have the information? Some of the states, for example, do their change of ownership under licensure and not certificate of need. So you could still regulate some of those pieces, but shift it over to licensure. So, and we're happy to provide more information for you if you would want. But again, there are other things they're doing than certificate of need in Europe. They're doing change of ownership. I think they're doing renovations. So you could take a look at that menu of services and you could shift some of those to licensure, or you could keep some of them under CON and just say, we want to exempt out these pieces.
You know, I don't want to speak, you know, I'm not in charge of managing your workflow contract, but in two areas that I would hope that maybe we could leverage HMA on is examples on the Pure State's approaches to collecting and update data with the forms to try to get the more updated information in a consistent manner. I keep on remembering Dr. Waits' example of a certain procedure that she said one provider reports it as A and another provider reports it as B. And, you know, we look at our state health plan, you look at the data, and it clearly doesn't reflect what's being done. So getting examples of other states do that. And then also specifics on adjusting the need criteria. I have a little bit of a concern about using utilization when we have so many beds that are not actually staffed, that kind of distorts the utilization criteria. But getting recommendations or thoughts as we move forward in the year on the needs criteria would be helpful. That's less a question for you and just for them to think about managing.
Absolutely, and don't want to, stymie the discussion in the room, but we do have a lot more information on alternatives to those criteria. Happy to provide those. Alabama, Tennessee as well that have made that shift. And also to note that that shift takes time. Like again, in Alabama, it was a 5 to 7 year process. And Arkansas had a really interesting way in which they did this. They set population levels. So instead of just multiplying by a factor, they would say if your counties that's less than 50,000, if you're 50,000 to 100. So there's, we can provide some of those options to you also that we could see. They could do that.
Do you think changes to CON should be done in a phased in manner if, as far as if the legislature was wanting to get completely rid of CON? Is that something that would be, could be accomplished without disrupting the healthcare system immediately, or should, if a legislative body wanted to, or a regulatory body wanted to institute changes, should changes to CON be more phased in and over a time period? Is that better for the health system?
This is just my opinion based on everything we saw and heard. I think it's an incremental approach. I think you have to, on the back end, watch for major disruptions, right? See what's happening. We saw this in Arkansas where they said to us, we let up on the hospitals, but then what happened on home health is we saw an oversaturation of home health. So then we had to come back in and we had to focus and adjust there. So I do think it's a phased in approach. And again, could you start with the phases where there's less risk? Like, again, people aren't building hospitals. We heard people say things like, we already know that, the people, if you're going to build multi-million-dollar hospital, we know they've been built. We don't think that that's, what's going to happen. So could you let that piece go? In some of these areas, again, primary care, behavioral health, could you start there? So I do think you could have an incremental approach. The question is on the back end, having the data and the staff and the capacity to then monitor that, to bring back to the board, to make sure that you're comfortable with that. So there would need, my opinion is you'd have to have resources devoted to be able to do that. And I don't know what that is. You all don't have an all payer claims database, but you could look at some of the databases that we have that look at facilities, market penetration, you do have access to that. And happy to provide some of those links to show you all where that data is. But I do think, even if it's just psychological, I think the incremental approach helps people wrap their brains around what's going to happen and how do we prepare. We saw in Georgia, for example, a whole year to 18 months of interim committee work where people were coming up with incremental approaches for how they're going to change their certificate of need program. So
When you describe the hospitals, nobody's building hospitals. What specifically, removing the CON on the number of beds in a hospital or removing hospitals from the CON process of they involved? What is your point of that?
my guess is there's just such a huge capital threshold you have to get over to even put the hospital up, right? And that what we were hearing is places where there's revenue that would justify that, or there's dollars to do that, those hospitals haven't been built. If you did though, think, and we talked about this a little bit last month, which is maybe you think there's a hospital that needs to be built, but economically, you're just never going to get anybody to do that because it's in an economically disadvantaged county. There are other ways that you can incentivize. So we talked about states that put up grant processes for public-private partnerships to help subsidize some of that big capital threshold you got to get over first. But that's what we were hearing, is that the hospitals where you have the economic benefit that would be able to cover the cost of the hospital, those hospitals have been built. But to your point, there could be a focus in the place where you don't have hospitals where you might want them.
You said what, that Louisiana and another state, I think you said Arkansas, have no CON for their hospitals.
Hospitals, correct.
So their hospitals can add a bed or take away or do whatever they want to without.
And that's managed in the licensure part of it. They're able to monitor that through licensure.
Very good.
What did you say about PRTFs in Mississippi? Did you say there'd been no CON activity? Did I understand that correctly?
The only CON activity is, I think there were 22 beds that were on the Gulf Coast that were moved to Jackson. That's the only activity that was happening.
Of course, PRTF did. Bill Creek didn't do it.
And that was quite something that was a, how do I say this? Misunderstanding of information. Some people said, oh, we've heard the department has not approved PRTF beds, and that's actually not true. There wasn't an application to build a new facility, new beds. There was that one shift though in the beds, the 22 beds.
PRTF.
Yes,
Tell us
PRTF.
what that acronym is.
Psychiatric residential treatment facilities that are mainly used by children in foster care or children that have very high behavioral health needs, very much like an inpatient acute setting, but not in a hospital. And those beds are really critical to CPS. I think they would like more beds.
Yes, Mr. Moody.
To remove the CON process, how would you recommend that we go about ensuring that facilities that are constructed or added on are in areas where they're needed and they don't just get an oversaturation in one particular area?
You asked the question in a different way, Mr. Moody.
Well, I'm just saying, if you don't have any type of certificate of need,
Right.
well, what if, the Hinds County, Madison, Rankin County area is a popular area for medical facilities. How can you ensure that one goes to Holmes County
Oh.
instead of another one being constructed right here in Hinds County?
Well, to be fair, that's happening now, even under your CON program. It's not shifting resources and facilities to the places where necessarily on that map, those colorless places. So that's happening. So the question is, what other levers do you have on the policy side to help shift existing beds to areas where they need it, or also manage the supply? So again, moratorium's an example, right? You don't need certificate of need per se, that we heard in some states when they have that moratorium on their SNF beds, right? They're able to control the supply that way. And then they also take a look at their layaway beds and they've revised a system there. So again, what are the policy levers you could use to push those services to the other part of the state? And we talked about grants, we talked about public-private partnerships. And some of these conversions that states are using, it could be that the state needs to put some money in for technical assistance to make that happen. If I'm a hospital and I'm thinking about converting to a clinic with a lab, I need someone to help me with a business plan. I need to think about how I'm going to retrofit my building, how I'm going to redo my staffing. So that could be another policy lever if the state was willing to provide dollars to help facilities think about different ways to convert. Not sure that 100% answers your question, but also happy to go back to you and pull some more examples. If that's helpful.
What effect do you think removing the CON process would have on the Medicaid budget?
Medicaid budget. So
That's okay. Oh,
So you've got two things. You've got Department of Health that's licensing the facilities, right? But then you also have Medicaid, which enrolls the facilities and the providers. And so clearly there's a link there, right? So Medicaid's not going to enroll a facility that Melissa and her group haven't licensed. So the question is the question around how much can the payer source interact with the supply and demand? Or is the question, can Medicaid go around this process and control the supply in a different way?
well, the question is how many more facilities would be eligible for Medicaid providers that are not, that would be utilized by Medicaid recipients that are not utilizing those services right now?
I don't know the answer to that. Because you license all the facilities in the state. And we did pull the provider directories for all your Medicaid managed care plans. So I can go back and take a look at that. If you want an idea of sort of the facilities that are licensed and the providers, we can take a look at that. You have 3 Medicaid managed care plans. You can take a look at that. It would be hard for me to believe that some of them didn't have the providers and the facilities in their network unless that's part of competitively coming up with the contracts and, having to go out and recruit those providers and facilities. But I can go back and look at that.
Excellent. Good questions. Margaret?
Caprice, thank you so much for working so well with us and helping us get this product to the board. On page 13, that map is really impactful. And I want to make sure everybody understands this, the map that's looking at CON application approvals compared to life expectancy. And so you see our typical counties in rural Mississippi, especially the Delta, Southwest, with no activity, with lower life expectancy and low approvals, but that's because there's low activity. It's not denials. In fact, we've had a couple of applications that we knew were necessary that were withdrawn voluntarily because there was some opposition, not an agency issue, but just, and the issue of resource that you point out, I mean, there are healthcare entities that just don't have capacity to fight it out, and there's opposition. When there's clear need, but you still got to fight through the process. That's expensive.
To that point, even if you did a CON exemption for some of those economically distressed, it's still only going to help get past that initial cost to submit the application and go through the process. There was one study we found in another state that said that cost to go through the legal fees and prepare the applications is usually between $125,000 and $130,000. Now, clearly, if you have opposition and more hearings, that's more and more legal fees. And we were told that could cost you just as much as a trial cost in terms of legal fees. So it's getting you past that hump. But then you'd also have to think about, capital expenditures or retrofitting buildings, and that's a cost that, clearly is not driven by that piece of it. But that $125,000, $130,000, it still is a formidable barrier.
You said that most of the applications from hospitals are about adding, services or equipment on the margin. And then there was also the note about, dialysis, end-stage renal disease services. And I believe in the data, it showed that there was a lot of the smaller hospitals were making the applications for dialysis. And we referenced that there was like basically a 95% approval rate. Does that apply to the Dallas's applications as well? And are we seeing those coming from the more rural areas?
I'd have to go back and pull those up. You're meaning for the ESRD. I'd have to go back and pull those specifically, happy to map them unless Melissa, you might know offhand, but I can.
Gary, I don't know that we've had a lot of formal applications. There's been a lot of requests to consider that type of exemption. And we can look to see how many applications have actually been made, but I think this goes to the situation that Clarice was talking about. A lot of applications aren't made because they know
The cost and
the
the
cost.
Yeah, so it's a chilling effect on expanding services in rural areas.
Yes, sir.
I do have the number of ESRD applications. That one up real quick. I can find it. So for ESRD, you had, for the last 7 years, 17, you had a cluster of them in 2017, 2018, where you had 6 in each year. And then you haven't had any since 2020. And again, if your question, Mr. Perry, is about where those came from, we can pull that up for you, show you the county locations for those.
It'd be interesting to see if they're urban or rural. I mean, my operating thesis, which maybe I will be wrong, is that if you're serving a smaller population, your margin on an absolute dollar amount is going to be smaller. And so therefore the cost in both time and money for legal or other administrative things matters more. So you're less likely to go through the process to go through the CON application process to try to expand that service in a rural area where your number of patients is likely to be smaller. And I'm curious if you would, after looking at that data, if you would agree or disagree with that statement.
I mean, my gut tells me that that's exactly where some of them are at. As opposed to if you look at the ambulatory surgical centers, which we heard a lot about, a lot of people talking about how there's that tension between hospitals and ambulatory surgical centers that are stood up by physician groups. Way fewer of those though than the ESRD piece.
Well, of course,
More
on the
clustered.
ASCs, you don't have a CON if
Right.
it's single purpose. So there's that aspect of it.
That's a huge component of that calculation is that single specialty the ambulatory surgery centers do not
You
require.
don't have to get, yes. And we heard from the hospital or some comments about people that represent the hospitals about, is that fair, right? Because then you can stand up an entire single surgical center and, you know, is that moved away from the inpatient setting to the outpatient setting?
Dr. Davis has some thoughts on that.
But much more activity there. You've had 6 in the last 2 years versus ESRD. That's pretty much tapered off.
Any other questions? Please, thank you so much and for y'all's great work. It's helping us. As far as any other old business, is there any other old business? There is, with that old business on the state health plan, is it the board's wish, can I have a motion to refer that update on the state health plan to the CON committee for review?
So moved with the expectation that I think we're working on a meeting for next week, just so we're.
And I think we're looking at Wednesday at 4 o'clock.
Wednesday at 4. Got it.
All right, is there a second, Dr. Davis?
Yep.
Very good. Is anyone opposed? All in favor? All right, so that, any other old business? We can't adjourn yet, however, I do need a motion to go into closed session. There is a legal matter that we as board need to discuss and we'll need to go into executive session. So is there a motion to go into closed session? All right, it does not require a second and we're in closed session. Thank you all. that the board wants to bring up? Do I hear a motion to adjourn?
Before we took
Oh.
took no action.
Forgive me, the board took no action. We discussed a legal matter and our two legal matters and took no action. And we are now adjourned.
Chairman, don't you hold